This very first module is the Introduction, History, and Philosophy of Palliative Care. The objectives for this first module are listed here, but I'll just go over them briefly. We're going to talk about palliative care and hospice care, the history, benefits, barriers, and some of the standards regarding hospice eligibility. We'll talk about the role of nurses in providing hospice and palliative care and the role of the interdisciplinary team, and relate that to the National Consensus Project guidelines. When we talk about hospice, we really need to talk from the very beginning and talk about the history of hospice and where hospice came from. So the term hospice actually comes from the same linguistic root as the word hospitality, and it can be traced back to medieval times when it referred to a place of shelter and rest for weary or ill travelers who were on a long journey. The name was first applied to the specialized care for dying patients by a physician named Dame Cicely Saunders, who began her work with the terminally ill in 1948 and eventually went on to create the very first modern hospice called St. Christopher's Hospice, located in the suburbs of the suburbs of London. Dr. Saunders introduced the idea of specialized care for the dying to the United States during a 1963 visit to Yale University. Her lecture, which was given to medical students, nurses, social workers, and chaplains about the concept of holistic hospice care, included pictures of terminally ill patients that she had taken and their families, and it really showed the dramatic differences of what these patients look like prior to having good hospice care and symptom management, and then what they look like after hospice care and symptom management. And this lecture is really what launched this chain of events in the United States, which resulted in the development of hospice care as we know it today. So the historic events, starting in 1965, Dr. Florence Wald, who was the School of Nursing dean, she invited Dr. Saunders to come and be a visiting faculty member at the School of Nursing. And then in 1967 is when Dame Cicely Saunders actually created St. Christopher's Hospice. In 1968, Dr. Wald took a sabbatical from Yale, and she went to St. Christopher's Hospice and to learn all that she could about hospice care. And then in 1969, another very historic event happened, and this was Dr. Elizabeth Kubler-Ross, who many of us have heard about. She wrote a book based on more than 500 interviews with dying patients and published it, and it was called On Death and Dying. And what it really did, what she identified, was those 5 stages through which many terminally ill patients progress. And if we remember all this from nursing school, remember it was denial, anger, bargaining, depression, and acceptance. And not necessarily that people had to go through those stages and one right after another. They could kind of bounce back and forth or be stuck in one stage. So this became an internationally known bestseller, and because of that, Dr. Kubler-Ross really started to make a plea for home care as opposed to treatment in an institutional setting, realizing how important it was to many patients and families that they die at home. And she argued that patients should have a choice and the ability to participate in decisions that essentially will affect their destiny. Some more historic events in palliative care. In 1974, Florence Wald, who, remember, she had went to England to learn about hospice care, along with 2 pediatricians and a chaplain, founded the very first hospice, and that was in Branford, Connecticut, and that was our first hospice in America. And then in 1974, Canada developed one of the first initiatives in North America, basically to identify and start hospice-based palliative care. So really, the Canadians were on board with palliative care before we were in the hospitals. And then another historic event happened in 1982, and that's when Congress passed the Medicare hospice benefit, which allowed us to receive reimbursement for hospice care. And then in 1997, the Institutes of Medicine, or IOM, put out a very, very important document called Approaching Death, Improving Care at the End of Life. And essentially what this document did is it really brought national attention to the deficiencies in end-of-life care in the United States. And it was essentially this document, and then the Robert Wood Johnson Foundation and the George Soros Open Society Institute, that really began a major effort to bring palliative care into mainstream medicine and nursing. And this is really when palliative care really started to become launched, and we really started to pay better attention to end-of-life care. Around this same time, other studies were being done that showed there was a huge lack of information in nursing textbooks and medical schools and things like that. And then in 2004, the National Consensus Project was developed, and what they did, this was the actual first clinical practice guidelines for palliative care, and they were published through the National Consensus Project for Quality Palliative Care. And what this is it's a coalition of end-of-life palliative care organizations such as HPNA, the Hospice and Palliative Nurses Association, AAHPM, which is the American Academy of Hospice and Palliative Medicine, CAPC, Center to Advance Palliative Care, and the National Hospice and Palliative Care Organization, or NHPCO. Many of those you may recognize the names. So, and then also the Joint Commission announced completion of its standards for certification for palliative care programs in September of 2011. So what happened was, with the development of hospice and palliative care, now we have the National Consensus Project, which actually developed guidelines to guide our care. And then very recently, just in September of 2014, the IOM made a second report, and this was basically, since 1997, so almost, 20 years later. And this report is called Dying in America. And essentially their key findings from this report were that we needed to, when it comes to palliative and end-of-life care, deliver person-centered, family-oriented care, that clinician and patient communications and advanced care planning need to be addressed. And then probably one of the third key findings was professional education and development, which is where we're at right now and why many of you are taking this course. And then also along in there becomes certification recommendations that specialists become certified. The fourth recommendation, or the fourth key finding, I should say, was policy issues and payment systems that need to be changed and reflect the current practices of palliative care. And then the last one, the fifth key finding, was public education and engagement. So essentially what this brand new IOM report does is, for those of us who work in palliative and hospice care, it's really not new information or real earth-shattering information, but what it does is it brings those key issues to a national level. Once it's kind of put out by the IOM, it will be acted upon by various organizations, through legislature, things like that, realizing the importance of those key findings, which is providing better care, but in addition to that, having specialized experts take care of our patients, educating our patients, having policies and payments that match that. Although it may take a couple of years for all this stuff to really start to be implemented, it's good to know that it's been once again brought to the national level, since that initial report in 1997. So as I talked about, one of the initiatives was certification. And so I really want to talk about the Hospice and Palliative Nursing Association, also known as HPNA. And just a little bit of history about HPNA. It actually started out as the Hospice Nurses Association in 1986. And what happens is you have HPNA, and then you have NBCHPN, which is the National Board for Certification of Hospice and Palliative Nurses, and they're the ones who actually run the exams, the certification exams. And in 1997, HNA changed to HPNA, recognizing that many nurses were doing palliative care in addition to hospice care. All of this was based on what's called a role delineation study. And so just a few little tidbits of information for you. You can see the very first certification exams began in 1992, and it was called the Certified Registered Nurse Hospice, the hospice nurse. And then in 1997, it changed to what we know today, which is the Certified Hospice and Palliative Care Nurse, or CHPN. 2002, they started doing one for CNAs. And then 2003 came the certification for Advanced Practice Nurses, which is CNSs and nurse practitioners. And then in 2004, LPNs. 2008, there's an administrative exam. And then in 2011 was the pediatric exam. And then just this past year, in 2013, the perinatal loss care exam, which is known as CPLC, was initiated. And the interesting thing about this last one, the perinatal loss, is it's not just a nursing exam, it's actually for all specialties. So nurses, social workers, chaplains could take this depending on what their background or specialty is. So that's actually pretty innovative. Okay, so let's get into some definitions here. I want to start off with hospice care and what hospice is. Probably several of you in this course work in hospice, but it's nice to know kind of what the differences are between hospice and palliative care. Hospice is considered the model for quality, compassionate care, of course, people facing a life-limiting illness. And what hospice care does is it provides expert medical care, pain management, and emotional and spiritual support tailored to the patient's needs and wishes. The support is also provided by the patient's loved ones as well, and it focuses on caring, not necessarily curing diseases. And in most cases, the hospice care is provided in the home, but it could also be provided in many other settings. And hospice services are available to patients with any terminal illness of any age, religion, or race. So there's no restrictions essentially on it. I'd like to talk about what hospice care includes. Hospice care includes an interdisciplinary team, hospice team, to manage pain and symptoms, emotional, psychosocial, and spiritual aspects of dying, which we're going to talk about that whole interdisciplinary team a little bit later. Provides the provision of the needed medications, medical supplies, and equipment. Provides education and instruction to patients and their family members. And then special services such as speech therapy, physical therapy, or maybe other complementary therapies if needed, or if they have the ability to offer those. And then short-term inpatient care can also be delivered when symptoms can become too difficult to manage or treat at home, or a caregiver needs respite care. And then bereavement care is also offered, and counseling to surviving family members and friends. And we're going to talk about all these things throughout the course. I'd like to talk a little bit about what the levels of hospice care are. So what we really need to know is there's home-based care, and there's basically inpatient care. So when you think about home-based care is routine. It's basically two kinds. Routine home care, which is the patient receives hospice care at home, the place that she lives or resides. Typically a nurse visit maybe once a week, every 10 to 12 days, a home health aide to go out, and chaplain visits and social worker visits. And then there's also something called continuous home care. And continuous home care is essentially when the patient receives around-the-clock care at home for maybe a crisis or maybe an end-of-life issue where you really need to have somebody in that home in addition to the family members. And typically many hospices use their LPNs for this to man the 24-hour care. It's not something that they can typically do for more than a couple of days at a time, but that's just a service that is offered, that needs to be offered. And then inpatient care, general inpatient care, and this is where the patient receives inpatient care for pain control or acute symptom management, which can't be managed at home or through continuous home care. They need to admit them, get the symptom managed, and then they can bring them back home to home hospice. And the other time that there's inpatient care is what's called inpatient respite care, and that's when there's maybe caregiver breakdown. The person taking care of them just can't handle it anymore, or they need a break, or it could be just that they have a vacation and they just there's nobody available to take care of the person at home, so they may have to put them in a long-term care facility or whoever the hospice is contracted with to provide this inpatient respite care. Okay, I'd like to just give you a brief definition of palliative care. So what's the difference between hospice and palliative care? In 2006, the National Quality Forum states, palliative care means patient and family-centered care that optimizes quality of life by anticipating, preventing, and treating suffering. Palliative care is throughout the continuum of illness and provides care that addresses physical, intellectual, emotional, social, spiritual, and needs to facilitate patient autonomy, access to information, and choice. Palliative care is rooted in the interdisciplinary hospice model of care, which was introduced in the United States over 30 years ago. I really like this slide right here. This slide essentially shows us what hospice and palliative care is. So imagine that somebody is diagnosed with a life-limiting illness or chronic disease or cancer, and this is where the diagnosis occurs right here. So essentially what happens is initially when somebody's diagnosed, much of their time is spent on curative treatment, life-prolonging intervention. For example, say this is a cancer patient. Most of their time is going to be spent getting chemotherapy, getting radiation, all of these treatments. And they're probably fairly healthy at this point. But what we need to do is we need to not wait until they're very sick until we start doing all these wonderful interventions that hospice and palliative care can provide. So what we want to do is start these interventions early. So if you start palliative care at diagnosis, when they're diagnosed with maybe cancer, and you see that the amount of palliative care that's provided in the very beginning stages is very small, maybe just a brief introduction to what palliative care is and what can be offered, just kind of planting the seeds for what they might need later on. And then as they go down their illness trajectory, and of course not everybody's trajectory looks like this, some are kind of wavy, and some are very quick, some are slower. But this just gives you a visual representation. So what it's showing is that as we go along this continuum of care, there's probably less and less curative or life-prolonging treatment, but there's more and more palliative treatments. And then what happens as we get towards the very end, or maybe the treatments are no longer working, or they're getting much more sick, is that we're providing mostly palliative care and very little curative or life-prolonging care. And at this point, this is when we need to start having the discussions about hospice care and when are they appropriate to have end-of-life care or hospice care. And then after hospice care is what's titled bereavement care, and this is the care that the patient and the family receive after the death occurs. So you see, it really is totally the continuum. Palliative care is the continuum of care that starts with diagnosis and does not actually end with death. It continues on past death and includes bereavement care. So the World Health Organization definition of palliative care, and I really like this definition, says that palliative care is an approach that improves the quality of life of patients and their families facing the problems associated with life-threatening illness through the prevention and relief of suffering by means of early identification and impeccable assessment and treatment of pain and other problems, physical, psychosocial, and spiritual. And I think this is an amazingly holistic definition. It really kind of describes what palliative care is. So when we think about palliative care, what is palliative care? I like to think of palliative care as the big umbrella. For example, all of hospice care is palliative care. And if you look at this little picture right here, you see on the right-hand corner here that all of the care that we're providing is palliative care. And hospice is one little piece of palliative care that occurs at the very end of life. And for the most part, the reason that it's listed like this is because it's the way our insurance system is set up, that it's hospice is a prognosis of 6 months or less. So that's just the unfortunate way, the way our system in the United States is set up. So what is palliative care? Very similar to hospice care, the interdisciplinary team. But the beauty of palliative care is services can be provided with curative or life-prolonging care, where hospice, for the most part, you have to no longer be receiving life-prolonging or curative type care. I shouldn't say life-prolonging, but curative care. And palliative care extends those principles of hospice care, so care can be provided much earlier in the disease trajectory. So I like to say palliative care is really hospice, all those wonderful things that we've been doing in hospice for years, it's now moved forward so patients can access these great things, symptom control, great management, earlier in the disease process, and they don't have to wait until they're no longer receiving curative treatment to get this wonderful care. So here's a nice little chart really talking about those differences between hospice and palliative care. So if you look here on the left, essentially hospice is a prognosis of 6 months or less. The physician needs to say, that your disease, if it follows its normal trajectory, that you will probably die within 6 months. Of course, that doesn't mean that if you live, past 6 months, that you'll be kicked out of hospice. There's just benefit periods, and you just become recertified and you can stay in hospice. But the focus of hospice is on comfort care. And when we talk about hospice, we talk about the Medicare hospice benefit, because the majority of patients who are on hospice are Medicare patients, although there are patients who have other types of insurance who are covering their hospice care also for those patients who are less than 65. And the other piece of hospice care is volunteers are a very important part of the hospice program, and there's other certain guidelines that hospices need to follow. And then palliative care, and we talk about palliative care, once again, it can occur anytime during an illness, and it can be combined with curative care. It doesn't matter who the insurer is. Some insurances are covering palliative care, some aren't. That's the unfortunate part about palliative care right now, is we just don't have a good reimbursement system for palliative care. So what happens is a lot of the palliative care programs are kind of hospital-based or inpatient-based, because hospitals maybe aren't getting directly reimbursed for palliative care, but what they're seeing is when patients receive palliative care consults in the hospital, they get better symptom management. There's help with care goals and decisions. Sometimes those ICU patients families and patients make decisions, and maybe they don't stay in the ICU so long. So essentially, it's the bottom line for hospitals. They're actually saving money by having palliative care teams. So that's how they're kind of funding palliative care in the inpatient setting. The outpatient setting for palliative care is newer. I mean, there's plenty of places that have outpatient palliative care services, but it's one of those we just don't have a great reimbursement system for it yet, but maybe at some point we will. So who should we consider for palliative care? So thinking about people who might be appropriate, anybody basically living with chronic and life-threatening injuries, and those injuries can be from accidents or other forms of trauma or chronic disease, other life-threatening illnesses, children, adolescents, adults with congenital injuries or conditions that lead to dependence on life-sustaining treatments or long-term care, and need to rely on others basically for their ADLs, some of those long-term care patients, younger patients that, for example, maybe cerebral palsy patient or someone who maybe has a shorter life trajectory. We can involve palliative care earlier in the disease trajectory. Of course, seriously and terminally ill patients, people with acute life-threatening injuries, our cancer patients, which we all know, people living with progressive chronic conditions, malignancies, strokes, lung disease, heart disease, CHF, all of those patients. And then patients who are vulnerable, underserved, under-resourced populations, homeless, immigrants. So basically, pretty much everybody could use palliative care at some point in their life, depending on what the illnesses are that they develop. This next slide talks about different settings where hospice and palliative care can be delivered. And I'm going to touch on this just very briefly because we're going to go more in depth towards the end of the course. But just to let you know that hospice palliative care can be delivered in all types of setting, from the home, the hospital, long-term care, assisted living, pretty much anywhere patients or families can be, we can deliver them care. Okay, so at the very top of here, of course, we have nursing. And when we think about nursing, nursing in the hospice team, we have RNs who are typically the case managers managing a patient load of patients. And maybe your hospice has some LPNs or LVNs who augment care. And then you may or may not have advanced practice nurses who are also seeing patients in your hospice. Then you have the primary physician who still typically manages their patients in hospice care, and many times the nurses actually are very autonomous, faxing or contacting physicians regarding orders and changes. And then you have the hospice or palliative physician, and then many times the hospice physician is kind of like the medical director overseeing all the patient care, and they may personally manage a couple of the patients, but for the most part, many hospices have the patients are still managed by their primary physician. And then we have our psychosocial professionals, and this is our this is our social workers, and they manage many of the psychosocial, emotional aspects of care, such as advanced directives, and deal with some of the community resources, community services, funeral arrangements, financial, legal issues that patients and families might be having. We have our spiritual care professionals. Typically, a hospice will have at least one chaplain, and the chaplain can be of any denomination, really, because their role is very interdenominational, and doesn't really matter what the patient's faith is. The chaplain will still go see them if the patient desires. Many times patients and families have their own pastors or priests, and they don't necessarily need the support of the hospice chaplain, but it is there for them if they want. The home health aide or CNAs provide basic physical care and family support, and really these are the people that spend the majority of the time with the patients, so they're the ones giving the baths at home, doing some basic care, and they're really your eyes and your ears in the home to let you know what's going on or what they see. So very valuable member of the team. And then we have caregivers, and the caregiver can actually be a family caregiver, or it could be somebody that's hired, or a friend, or somebody who's volunteering. They can help with all kinds of different things depending on if there's somebody that's hired and paid, what their limitations are, or many times it's mostly patients that's family caregivers. And then we have volunteers, and the volunteers are a really important part of hospice care. Volunteers can do all types of things. They can go in and sit and visit with patients and families, go do their shopping for them, take them to appointments. They may do different types of therapy if they have those skills: pet therapy, art therapy, music therapy. Some actually volunteers spend time with patients and family, direct support, or some actually do other types of clerical clinical support where they help maybe in the office doing paperwork and things like this, or helping with fundraising. It's real important though that a certain percentage of your hospice has to be volunteer hours, so it is a required component to be a hospice by Medicare. So that's why one of the reasons why the volunteer component is so important. So I want to move on and talk a little bit about the dimensions of care. We've talked about what hospice is, what palliative care is, and what the team actually looks like, but let's talk a little bit about the dimensions of care. So we think about providing hospice palliative care. One of the first things that comes across to me is Dr. Ira Byock, who authored a book and has actually done some work on this quality of life index. And it's a really way to measure quality in hospice patient, and it looked at 5 dimensions of care. The first one being the physical symptom dimension, and this is where patients experience the physical discomfort associated with the disease process. what kind of distress are they having? What kind of distress are the caregivers having? And this is a big part of the care that we provide, is actually, addressing those physical symptoms. And then there's the functional dimension. How able are they to perform activities of daily living, social function, paying their bills, doing their job if they're still working. How is this disease impacting their life? That's another dimension of care that we address. The interpersonal dimension, their investment in personal relationships, quality of relationships with family, friends, others, caregivers. How is this being addressed? And then their well-being dimension. This includes basically, how is their sense of well-being? How do they feel about themselves? Do they have anxiety, depression, sadness? Do they have a sense of peace? And then the last one being the transcendent dimension. And this is kind of their connection and relationship on a transpersonal level, maybe spiritual or religious values. What is the meaning of life, suffering? So when you look at all these dimensions of care, this is how we kind of measure the work that we're doing. Are we addressing all these? Are we making sure that all these things are as good as they possibly can be for this patient, so that we can understand that, if we're addressing each one of those, we're really making the best approach to care. I want to talk about the National Consensus Project. Remember, I talked about that quite a bit earlier. I want to talk about, if you were developing a palliative care program, these are the essential things that have to be addressed. They're essentially the guidelines that say, in order to have a quality palliative care program, you have to have these things in place. So the first one here, and I've actually linked to the National Consensus Project. It's actually on your supplemental materials, so you'll be able to see that, and I would actually download that and save it to your computer, because it's pretty important to read through. It really talks about, the first domain, structure and processes of care. How do we provide care? What kind of things do we do? What does a team look like? What are the qualifications, education, training, support, all of that stuff? That's all your structure and processes of care. The second one is the physical aspects of care. How do we actually provide care? Do we use validated tools? How are we managing symptoms? With what kind of modes are we using to managing symptoms? The third one, psychological and psychiatric aspects of care, making sure that we are addressing all of these things with our patients. Social aspects of care, community engagement, supporting their strengths, helping the family. Domain number 5, spiritual, religious, and existential aspects of care. How are we addressing their spirituality? Number 6, are we looking at those cultural aspects of care? How are we making sure we're providing culturally appropriate care to our patients? Number 7, care at the patient of the end of life, those what we call final hours. How are we addressing that? And then the last one, ethical and legal aspects of care. So if you look at all these domains, essentially, if you look at the actual National Consensus Project book that I've actually attached, you'll see that under each one of these are guidelines and recommendations of how to make sure you're implementing this in your program. So, wonderful document. I want to talk briefly about the nursing plan of care. We think about our role is really to work with the patient, but not only the patient, but the family, to really minimize suffering from those physical and functional decline that comes with this disease progression. Really should focus on quality of life, right? Because that's what we do. We don't necessarily give quantity, but we can definitely enhance their quality of life and focus on what the patient's needs and wishes are for that point. Really involves 3 really broad dimensions when we think about what we do as nursing care. Approaching care from the patient and the family experience with a real interdimensional focus, meaning that we're using our team, but we're not just looking at the patient's pain, for example. We're also looking at their environment, what kind of things are going on around them, what are they worried about, what are they concerned about. That's an interdimensional focus, those things that I talked about earlier. That we have expertise in management of the disease and symptom management of our patients, and that we're applying the nursing process as a member of the interdisciplinary team through our critical thinking, so that we're participating in a team. We know when to ask for social workers support. We know when to ask the chaplain, maybe this patient needs a chaplain visit. So let's talk a little bit more about this comprehensive assessment. So we just go through the nursing process here, right? Our assessment. So before beginning the physical assessment, we establish the relationship with the patient. We do the physical assessment, psychosocial assessment, spiritual assessment. And then essentially we make our diagnosis. Every visit, it might be something a little bit different. We have a plan of care for our patients. We're doing an assessment of that. We're doing a diagnosis, a nursing diagnosis, and then we're planning out through the IDT, through the interdisciplinary team, collaborating with all of our members to reflect what the goals should be for this patient and what our interventions are going to be. And then, of course, always evaluating, and that we're also not just evaluating the patient's response, that we're evaluating the family's response to treatment also. I want to talk about communication and goals of care and what our role is. So really, as palliative nurses, we are experts at having these discussions with patients and family regarding goals of care. We develop a plan of care, evaluate the outcomes based on the patient and family goals of care, make sure that the documentation is in place and the patient's preferences are honored. We advocate for the patients and their family, making sure that their wishes are honored. And we realize that the patient is the center of care, and the plan of care is really directed by the patient and family goals of care. And surrounding this is, as nurses, experts in hospice and palliative care, we really are experts in communication skills, such as presence, which is the art of just being there, listening and supporting patients, providing the appropriate amount of information necessary for them to make decisions. So basically the right dose of information. And then sharing information about symptoms, palliative care, all of those things that our patients and families need. And then, so in order to do all of this, the nurse needs to be knowledgeable, right? And that's one of the reasons many of you are taking this course, enhancing your knowledge, learning more, so that you can advocate for patients and that you really are an expert in your field. And when you think about some of the ways that we communicate with patients and family, you know, open-ended questions can be very helpful. Things such as, tell me about your condition, or how much do you know about your disease? How much do you know about your cancer? How much do you want to know about your cancer? You know, other questions to help frame, how do you make decisions? All these things here. What's concerning you? That's probably one of my favorite is, you know, what are your biggest concerns? What are you most worried about? What are you most concerned about? And that kind of can direct a goal of, you know, what's important for this patient and family. If they've got 2 weeks left to live, what's going to be important for those next 2 weeks? And that really helps us to develop a very personalized plan of care and nursing diagnosis. I want to talk a little bit about resource management. So originally hospices were funded mainly by charity, grants, volunteer efforts, and you may even meet some hospice nurses who've been in long enough to say, well, I worked in hospice back when I was a volunteer nurse, because there were a good amount of nurses who just volunteered their time initially when hospice came out, before the hospice Medicare benefit, before they were actually able to get paid. So today, for the most part, the Medicare hospice benefit is what the main source of most payment is. Although there are private insurance companies, like I said earlier, that do reimburse for hospice care. And then access to care, you know, often our patients are referred to hospice for a few hours or days before death, which is too late. We want them to have optimal care. So ideally, if the hospice Medicare benefit is 6 months or less, wouldn't it be wonderful to have, you know, all patients referred to us and they could spend, you know, 5 or 6 months on hospice care before they died? But unfortunately, that's not the case for many different reasons, you know, lack of information, lack of care, lack of referrals, many different reasons. But so, and then, like I said, palliative reimbursement, we just really haven't gotten quite there yet. I do want to mention, though, that Medicare hospice benefit pays if the criteria are met and documented, and we're going to talk about that in a later chapter, because it's pretty much based on the disease trajectory as to, you know, when they're going to be eligible for hospice care. But in order to be eligible for hospice care, the patient must be entitled to Part A of the Medicare benefit, and they have to have that certification from a physician that they're terminally ill, considered to be terminally ill if their medical prognosis for life expectancy is 6 months or less if the disease runs its usual course. So the Medicaid coverage for hospice is very similar to the Medicare hospice budget, but states do have flexibility in how they develop their hospice benefit for Medicaid patients. And then, of course, we have private insurances, and most of those have really modeled themselves after the Medicare hospice benefit. So, palliative care. Really, like I talked about earlier, we really don't have a good reimbursement system for a palliative care yet, and that's why many hospitals are just kind of eating the cost, essentially, because they know it's saving them money in the long run. Many of you have heard of what's called the conditions of participation, the hospice conditions of participation. So essentially, hospices who are certified by Medicare to provide care agree to follow the hospice conditions of participation, also known as the COPs is what we call them. The hospice COPs were originally published in 1983, and then they were updated and revised in 2008 to focus on a patient-centered, outcome-oriented, transparent process, which makes it a little bit better and kind of holds hospices a little more accountable. But unfortunately, it causes hospices to have to do a lot more documentation, quality improvement efforts, pretty much holding us to many of the same standards as hospitals. So the COPs are a set of core requirements for hospice services that encompass patient rights, comprehensive assessment, patient care planning and coordination by the hospice interdisciplinary group, or IDG, and the focus really is on ensuring that the hospice furnishes care that meets the essential health and quality standards, ensuring that it monitors and improves its own performance, process improvement. And the principles that pretty much guide the COPs are, number one, a focus on continuous integrated healthcare across that process that provides patient and family experiences across all aspects of hospice care, and really center around care planning, service delivery, quality assessment, and performance improvement. Number two, it's a patient-centered interdisciplinary approach that recognizes the skill of the various providers. And number three, it's an outcome-oriented quality assessment and performance improvement program that needs to be incorporated by hospices. And then how the hospice meets performance expectation. There is some flexibility allowed in that, but there's also some recommendations and performance measurement systems that need to be evaluated. And I can provide the link for that also, which is going to be in your handouts that are attached to this. So you will have the link to the latest information from what we call CMS, or Center for Medicaid Services, which really regulates the hospice benefit. Okay, and one last thing I want to talk about